In this lecture, we will discuss premature ventricular contraction, including its origin, mechanism, EKG features, terminology, potential causes, and clinical significance. Premature contractions are complexes that occur earlier than expected. Therefore, premature ventricular contractions, or PVCs, are complexes that occur earlier than expected, originating from an ectopic focus within the ventricles. They are often the result of an unusual irritability of automatic pacemaker cells within the ventricles. Now, in terms of causes of PVCs, there are many, including anxiety, myocardial ischemia, hypokalemia, hypomagnesemia, and many drugs such as excess caffeine, beta agonists, sympathomimetics, and digoxin toxicity. Now, clinically speaking, PVCs are often benign and require no treatment. They also may be a trigger of reentrant tachyarrhythmias. Now, while they are often benign, they may actually be potentially lethal in the setting of prolonged QT interval by setting off torsades de pointes, which is a polymorphic ventricular tachycardia. Okay, so let's go back to the basics. Why do these ectopic beats come about? Well, there are groups of pacemaker cells throughout the conduction system that are capable of spontaneous depolarization, just like the sinus node. The intrinsic rate of depolarization of these pacemaker cells decreases from top to bottom along the conduction system. That is fastest in the sinus node to slowest in the ventricles. And the general rule is that the fastest pacemaker controls the heart. So if we look here, we have our sinus node up here, okay, that has usually the fastest intrinsic rate in adults between 60 and 100 beats per minute, okay? Then as we continue to progress down through our conduction system to our internodal pathways, to our AV node, the His bundle, okay, to our bundle branches, and then to the Purkinje fibers, the conduction system or the intrinsic rate of these will slow down, okay? So normally these ectopic impulses are more like secondary pacemakers that are suppressed by the more rapid impulses that originate from above them. However, if an ectopic focus depolarizes early enough, that is before the arrival of the next impulse, it may capture the ventricles, producing a premature contraction. These premature contractions or ectopics are then classified based on their origin. For instance, a premature ectopic beat originating from the atria is called a premature atrial contraction, or PAC. A premature ectopic beat originating from the AV junction is called a premature junctional contraction, or PJC. And then a premature ectopic beat originating from the ventricles is called a premature ventricular contraction, or PVC. And our focus here is these premature ventricular contractions, so those that are arising from the ventricles. Okay, and you can see that here. You can see our beat arising from here within our left ventricle in this case, okay, and that's what's going on. And what we have going on is it's firing before our sinus node can even get to the ventricles. All right, so it's outpacing our sinus node and firing before it gets a chance to go about. So what can we see on the EKG? Well, in general, PVCs often lack P waves and have QRS complexes that are wide, bizarre appearing, and occur earlier than we would expect for the next sinus impulse. The QRS morphology is quite different from that of other sinus beats. The QRS interval is prolonged because intraventricular conduction is occurring outside the normal conduction system via cell-to-cell depolarization, which is a slower process and prolongs ventricular depolarization. So if you look here, we have our normal conduction system, okay, where we started from our sinus node and went down through our AV node and through our bundle branches, but instead we have this coming from an ectopic site within our ventricles, okay, and because of that, we'll have cell-to-cell depolarization, which is a slower process outside of our conduction system. So think of our conduction system as the highway path, okay? It's a faster route and everything will occur faster. But in this case, if we're outside of it, in this ectopic focus, everything will occur slower. And because it occurs slower, our QRS interval, representing ventricular depolarization, will be widened, okay? So everything will be prolonged, and you can notice here, it's much different than our narrow QRS complex, okay? Notice how their PVC here is wide and bizarre appearing. Now, one thing to note is that you may have retrograde capture of the atria, in which you may see retrograde P waves with an abnormal axis occurring after the QRS complex, okay? So what we're saying here is if you have our, okay, so we still have our beat originating from this area, and it'll depolarize all the ventricles, but for what if it goes back upwards, okay, and it goes retrogradely and starts activating the atria? In such cases, you may see an abnormal or inverted P wave, okay, going opposite in direction to our normal sinus rhythm, okay, or sinus P waves. So it's going backwards, and we can see a retrograde P wave. Okay, so this doesn't always happen. More often, you don't have a P wave or C1, but that's something that can occur. And in those cases, you see inverted P waves in the inferior leads as it goes away. Remember, our inferior leads are down here. We have 2, 3, and AVF. So as it heads away from it, it would be inverted in those leads. Okay, so what else can we see here? Well, we're going to see discordant ST segment and T wave changes. Now, discordance describes a repolarization abnormality pattern in which the ST segment and T wave are directed opposite to the main vector of the QRS complex. For instance, in the example here, we can see ST segment depression and T wave inversion with the dominant R wave. Okay, so if you look here, here's our PVC. We have our QRS complex, and this is a dominant R wave that we see here. And then coming down, if we look at our baseline here, we can see that the ST segment is slightly depressed, and our T wave here is inverted. So we have T wave inversion. Okay, so notice our QRS complex mostly positive, ST segment and T wave going in the opposite direction, and we call that discordance. Okay, they're going in the opposite direction, and that's what discordance means. If they were going in the similar direction, we call that concordance. Okay, so during these PVCs, seeing this discordance is a common thing. Now, if instead we had a dominant S wave, we could see ST elevation and upright P waves. Okay, so if we just erase this here, if instead our PVC, and in some leads you may see this, we had a dominant S wave, we may instead then see ST elevation. Okay, so here's our dominant S wave going down, and our ST elevation and upright T wave in this area going up. Okay, so that's discordant, again, going in the opposite directions, and it's something common here in these PVCs. Okay, so one more thing with EKG. Normally there will be a full compensatory pause following the PVC. In other words, the beat following the premature beat will occur when it normally is expected. That is, it compensates for the premature beat and does not affect the overall timing of those beats that follow. So what we will see here is that the next normal beat following the PVC occurs after an interval that is equal to 2 times the preceding R to R interval. Okay, so let's just look at this. So we're saying there's a compensatory pause, and what do we mean by that? So here's our R wave, and here's our next R wave. So we call this the R to R interval. Okay, and if we were to have the next R wave occur, it would come at this point. All right, and the one that followed would occur at this point. All right, and why this is a premature beat? Notice our R wave should come here, but it's coming earlier, so that's why it's premature. Okay, ventricular because it's wide, all right, and coming from the ventricles. Okay, and what we are saying here with this compensatory pause is that even though this beat is coming earlier, we still get the next beat occurring as it is expected. Okay, so right here the sinus node decides to fire, okay, at its normal pace, and then it fires, and this is where the next R wave occurs. Okay, so if you were to count that out, we still have our normal R to R intervals. Okay, so this is one R wave to the next, our first R to R interval, and then from this point until that represents 2 R to R intervals. So because it's occurring where it normally should, we call that a compensatory pause. In terms of determining the origin of a PVC, the QRS morphology can help us out. For instance, a PVC originating from the right ventricle will often have a left bundle branch block morphology. That is a dominant S wave in lead V1. All right, so let's look at this here. So if we erase what we have here, and now we're saying that instead of coming from the left ventricle, we have it coming from the right ventricle. So imagine it right here from this impulse. So it's going to spread its way throughout the ventricles, okay? And remember, lead V1 sits right over that right ventricle. Remember, the right ventricle is the most anterior portion of the heart, and lead V1 and V2 are our right precordial leads sitting right over our chest and over our right ventricle. So if you have the beat originating from the right ventricle, it's going to spread away from it, okay? So one of the things we'll see is if it's coming from the right ventricle, we'll see these dominant S waves, okay? S waves are those negative waves. Remember, this would be an R wave, and S wave would be one that would go downwards, okay? And remember, an S wave is the first negative deflection after an R wave. Okay, so dominant S wave that we see there. Now, what if it was coming from the left ventricle? Okay, in this case, we would see a right bundle branch morphology, and that means we would see a dominant R wave in lead V1. Okay, especially that terminal portion. So now we're saying that it's coming from the left ventricle. Okay, as we see here, notice this is our left ventricle. It's originating from there, and it's coming towards lead V1. Notice the impulse is spreading in the direction, going rightward or anteriorly toward V1, And because of that, we see this right bundle branch block morphology, okay, where we see the terminal QRS having that dominant R wave, okay? So a little more advanced stuff, but I think you can handle it. Okay, so there's also some terminology I want you to be aware of. You may have heard of unifocal or multifocal PVCs. Unifocal PVCs are simply those originating from a single ectopic focus within the ventricles, and therefore each PVC will appear to be identical. On the other hand, multifocal PVCs are those originating from two or more ectopic foci within the ventricles. And because they're arising from more than one area, you will see different QRS morphologies. So if you look here in our example, we're only looking at a unifocal PVC, right? It's coming only from this area, so we only have one PVC, all right? Now, if we were to have a multifocal, imagine one coming from that area, but we also have an area in the right ventricle, okay, that's initiating one. In such cases, it would have a different morphology than we see here, okay? Similarly, if we had one originating from this side, okay, so we would call those multifocal, where they have more than one foci, more than one ectopic foci where they're originating from, and because of that, more than two morphologies. So that's unifocal versus multifocal PVCs. Now, some other terminology has to do with the PVCs that occur in repeating patterns. In other words, if every other beat is a PVC, we call that bigeminy. If every third beat is a PVC, we call that trigeminy. And if every fourth beat is a PVC, that's called quadrigeminy. Okay? So those are single PVCs occurring between normal beats. So if we look at that here, all right, imagine we have a normal beat, then we have our wide complex, normal beat, wide complex, okay? Normal beat. It's occurring every other one, and we call that bigeminy, okay? So that's bigeminy, every other beat is a PVC. Now if we had one occurring every third beat, all right, meaning we'd have normal to normal, and then our PVC, to normal, then our PVC, and so forth, we call that trigeminy, all right? And if there were three normal beats and then the fourth beat was a PVC, three normal beats and the fourth beat a PVC, we call that quadrigeminy, okay? Now if we have two consecutive PVCs occurring in a row, we call those couplet PVCs. And if there were three in a row, that would be triplet PVCs, okay? So again, all we're saying is if we have these normal complex and then a wide one, okay, then normal, these two in a row would be called couplet PVCs. If there were three in a row, triplet, okay? Anyways, I wanted you to at least hear this terminology that's sometimes used. All right, let's go through our chart here before we end. So PVCs are just early beats originating from an ectopic focus within the ventricles. The general rule we said is that the fastest pacemaker controls the heart, and in this case, we have a pacemaker within the ventricles that's outcompeting our sinus node or anything above it. And that's why it's coming about. The mechanism is usually a result of irritability of an automatic pacemaker, as we see here within the ventricles. We mentioned a number of causes that are listed here. Remember clinically significance of this? They're often benign. You could see some palpitations with some of these. Often there's no treatment, but the thing to be aware of is if there's a long QT interval. Okay, if that QT interval is long, okay, you want to be aware of that because that can precipitate out torsades. All right. Now remember, we have discordant ST and T wave changes, where our main vector in the QRS complex is going in the opposite direction of our ST segment in T waves. Okay, so that's a normal thing that we'll see in these PVCs. We mentioned the compensatory pause, where we continue to stay on our same cycle, okay, and the overall timing of this is not affected. We looked at the origin. Remember, if it's coming from the right ventricle, we're going to have dominant S waves in V1, and if it was coming from the left ventricle, we would have those dominant terminal R waves in V1. The pattern overall is irregular, okay, because even though we have this compensatory pause, we have this PVC occurring where it normally shouldn't, okay? It should occur at this point, but it's not, so this is an irregular rhythm. The underlying rate, okay, of the rhythm will determine the overall rate. Remember, the P waves are often not present, but you could have that retrograde P wave if you have that retrograde atrial conduction where it goes backwards, okay? In that case, you will see that abnormal P wave axis. Again, the P wave to QRS ratio, you often don't have one because there are no P waves present, and that's the same thing with the PR interval. No PR interval because no P wave present. Unless you have those retrograde P waves, then you can consider them. The QRS interval, this is one of the main things. Our QRS interval, in this case, will be prolonged, okay? We're coming from the ventricles. We have slow cell-to-cell depolarization outside the normal conduction system, so things will be prolonged. That's one of the main identifiers that can tell you that you're dealing with a ventricular origin, okay? But you also have to be aware of sometimes you can have supraventricular rhythms or impulses that have aberrancy and can also appear wide. That's a little more advanced than something we need to talk about now, but that's something to be aware of, okay? So wide QRS complexes, because it's coming from the ventricles, abnormal QRS morphology compared to those that come before and after, okay? And again, no grouping and generally no drop beats. We then talked about the terminology and went through that all. Well, that's the end of this lecture. We discussed premature ventricular contraction, including its origin, mechanism, EKG features, terminology, potential causes, and clinical significance. I hope you learned something.